shift gears a little bit and talk about the sarcopenia and tips and how sarcopenia is associated with different things that are related to tips. These are my disclosures. So as a background, there are several methods where you can predict mortality after tips. So when you do tips, we're going to see how the patients are going to do, which patients will survive better than the others. One of them is the MELD score, which relies on several laboratory factors. However, MELD has been verified and validated as a predictor of short as well as long-term survival after tips, but it has its own limitations because it relies only on lab factors, which is creatinine, bilirubin, and INR. But it does not take into account the nutritional or functional status of the patient. So that's why we need another more optimal index that can really predict survival after tips, and sarcopenia seems to be a promising one. The definition of sarcopenia is decrease in the muscle mass of at least 2 standard deviation below the normal healthy young adult. So it is seen actually in aging and also in chronic diseases such as malignancy as well as cirrhosis. And sarcopenia has been actually used to detect mortality in patients who have cirrhosis. So it's actually used as a surrogate for predicting mortality with cirrhosis. So the problem with using sarcopenia with in patients who have cirrhosis, using a body mass index as a measurement of sarcopenia in patients with cirrhosis is that we all know that in cirrhosis there is hypoalbuminemia, which leads to fluid retention. So these patients will have a normal body mass index because the weight is normal because of the fluid retention, but actually this is just fluid. They still lose muscle, so they still have sarcopenia. So it's not using the body mass index as a measure of sarcopenia is not really a good one. So people started to, or investigators started to use the area of the major muscle groups as a measurement for sarcopenia. For example, this group used they do like a region of interest. They draw it over the major muscle groups in a CT image at the level of L3, which is basically mid-abdomen. And they calculate the volume, the area of that, and use that as a measurement of sarcopenia, and then correlate that with mortality later on. Other groups started to say, why do you want to measure all these muscles? They just measure the psoas muscle as the muscle that represents sarcopenia. And they went along the pathway of even using the maximum diameters of the muscles, basically APF, lateral, directions. And they found that even measuring it this way is equivalent to using the whole area or drawing a region of interest around it, and it correlated, significantly together. So the problem with these techniques when you measure areas is that it varies significantly with age and ethnicity. For example, a normal person with a certain ethnicity might have bigger muscles or more muscles than another normal person, but in a different ethnicity. And so you cannot really rely just on absolute area to say, well, this patient has sarcopenia, because it just depends on the ethnicity and age as well. So we developed another way, which is by using the density of the psoas muscle instead of using the area of the psoas muscle, because we all know that in sarcopenia, the muscle mass decreased and is changed into fat. And so when you measure the Hounsfield units or the density of that muscle, it will be less than the normal. So we did the same thing at the level of L3, which is mid-abdomen, but as you can see here, we did a region of interest around the psoas muscle, which is seen in yellow here, and we measured the Hounsfield unit of this area. And with that, we used the muscle density instead of using the psoas muscle density, instead of using the psoas muscle area. And then we did a study to see how the psoas muscle density can correlate with mortality after tips. So we retrospectively reviewed 241 patients, and the first thing that of course affects mortality is the indication for tips itself, which is either variceal bleeding or volume overload. So we wanted to get that out of the way, and we found that the mortality because of the indication is actually not significant. So those patients who had TIPS because of bleeding did not really die more than those who had TIPS for volume overload, which is ascites, refractory ascites, and hepatic hyperthorax. We looked at the MEL score as a measure of, predicting mortality, and we found the same that is published everywhere, which is the number 15, the famous number. Patients who have a MEL score less than 15 survive better, which is represented here by the blue line. They survive better than the patients who had a MEL score of more than 15, which survived less. And then we looked at the psoas muscle density. We found that the cutoff was 29 Hounsfield units. So patients who had a Hounsfield unit that is more than 29%, in other words, they have better muscles than those who had a Hounsfield unit less than 29, which is represented by the red line here. These are the patients who had less muscle mass. Those who had more muscles, or more muscle mass, actually survived better than those who had the Hounsfield unit less than 29, and that was also statistically significant. So we wanted to see if we can combine both the MELT, which is already established and used, and see if we can add to it another, metric that can be used to distinguish those who will survive better than the others after TIPS. So as you see here, this is the ROC curves, and when you use MELT only, this is the blue line. But when you use MELT and psoas muscle density, your ability to predict mortality is actually much better because the curve is higher away from the median here. So that's at 12 months. And then we looked at how these combined variables look together. So the best mortality here, of course, was found when you have a MELT score that is less than 15 and a psoas muscle density that is more than 29. While the worst survival, which is the green line here, is when you have a MELT score that is bad, which is more than 15, and a psoas muscle density, which is also bad when it's less than 29. And in between, there was the mix of, psoas muscle density and MELT score. But again, if you measure the psoas muscle density and you get the MELT score, and the MELT is less than 15 and the psoas muscle density is more than 29, that correlates with the best survival outcome after TIPS. Another group later on, 2 years later, did the same thing. They looked at retrospectively at their group of patients who underwent TIPS. Again, found similar results, but with different numbers. The cutoff that they had instead of 29 was actually 49 for the group. But they found, again, on the ROC curves that psoas muscle density actually, so they used the density this time, not the area, they found that the psoas muscle density actually has the best indicator for mortality after TIPS compared to MELT sodium, and CHART-Q. And they found that the cutoff is 49. In our study, we find it to be 29. So those who had a psoas muscle density of more than 49, in other words, they have better muscles than those who had less than 49, survived better after TIPS. So what about gaining muscle after TIPS? Do we gain muscles after TIPS? Does the sarcopenia improve after TIPS? Indeed, it does. In this study, which is also a retrospective study, 76 patients done in Dotter Institute, they found that all the parameters here, all the muscles increase after TIPS and maximizes after 6 months. It reaches its maximum after a month, and then it plateaus a little bit. And again, that is something good with TIPS. In addition, they found that those patients who had the increase in their muscle mass actually had a lower mortality compared to those who didn't. They did not find any difference in the demographics or other clinical variables. In other words, the increase the improved mortality after gaining muscle was not related to other factors like the age, the sex, or other clinical parameters or lab values. What about sarcopenia and hepatic encephalopathy? meta-analysis that is done on 7 studies with a total of almost 1,100 patients. And it showed that sarcopenia increases the risk of post-hepatic encephalopathy. In other words, if you have sarcopenia, then you undergo TIPS, it's more likely that you'll get encephalopathy afterwards, and we'll see why. And that was statistically significant. They found it to be more common in Asian population compared to non-Asian population, also for those who had alcoholic cirrhosis compared to non-alcoholic cirrhosis, and also for those who had normal, almost like normal MELD score, I would say less than 12 in this study, compared to those who had more than 12. And the reason, if you want to correlate this, why do these patients really who have sarcopenia, they get encephalopathy after TIPS? What is the relation between the muscle and encephalopathy? So we all know that there is like neurotoxins that develop in the GI tract, and they go into the portal circulation to the liver, which filters out these neurotoxins. But when you have TIPS, these neurotoxins, they go through TIPS, they don't get filtered, and they go into the systemic circulation and then to the brain to cause what is known as encephalopathy. The muscles actually act as a secondary site for detoxification of these neurotoxins. So when you have a decrease in the muscle mass, the ability of the body to get rid of these toxins also decreases, and that's why these patients are likely to get encephalopathy. So in summary, sarcopenia is an independent predictor of survival in patients who undergo TIPS. Sarcopenia can be assessed by measuring the psoas muscle density instead of measuring the area at the level of L3, which is mid-abdomen. The measurement of psoas muscle density in conjunction with the MELD score improves the predictability or survival predictability after TIPS. Sarcopenia is a risk factor also for post-TIPS hepatic encephalopathy. In terms of future directions, one thing that we can still study is if this patient has sarcopenia, we know that doing TIPS for him is probably going to result in, poor outcomes in terms of survival or mortality. So why not try to do aggressive or intensive nutritional therapy before we do TIPS to improve the sarcopenia? If we can, of course, not in urgent cases, not in bleeding cases, but maybe in cases where we're doing this for like elective cases for ascites or those cases where controlled bleeding, maybe we should improve the nutritional status, let him gain muscle mass, and then do